Good afternoon, everyone, and welcome. This is the Institute of Medicine of Chicago's session on cannabis, everything you need to know about cannabis in the 21st century. This session is the 18th session of the 8th convening of the State of the Health of Chicago, and we're delighted that you're with us today. I'm Cheryl Rucker-Whitaker. I'm the president and chair of the Institute of Medicine of Chicago. We've got a very full presentation, so I'll be brief with my remarks so that we can get to our speakers today. Today's agenda includes presentations from 3 experts who have numerous years of experience addressing this topic. There are numerous regulations and guidelines, and our primary focus today, though, is its therapeutic uses and how it's beneficial. We'll have a Q&A at the end of the presentations. On behalf of the Board of Governors, it's my pleasure to welcome you. I'd like to pay a moment of respect to our past board director, Dr. Leslie Sandlow, who passed away this summer, and we thank him for his inspiration, dedication, and commitment to the Institute of Medicine of Chicago and healthcare. His career spanned over 50 years, and he will be missed by many of us. Our mission is strong, and we're very confident in our efforts as we move forward. We're celebrating our 106th year, and we're proud to continue to draw on the perspectives of a very diverse membership and other regional leaders to address critical health issues. I want to share a few upcoming events. On December 17th, the Institute of Medicine is pleased to welcome Andy Slavitt, who will talk about his new book, Preventable, the inside story of how leadership failures, politics, and selfishness doom the US coronavirus response. Andy was a former CMS director and has a great deal of experience and expertise across healthcare. We'll also be presenting the IOMC Healthcare Awards at this event, and we hope that you will join us to recognize our colleagues for their great contributions. In 2022, we continue to have a full calendar of programs. In January, we'll present a summary report of the State of Health of Chicago. In February, we'll talk about mental health, suicide, and trends. March, we are addressing homelessness, the crisis, and solutions. In April, we're partnering with Rosalind Franklin to talk about the intersectionality of education and community engagement. And in May, we're talking about chronic kidney disease and its disparities. On June 2024, it'll be here before we all know it of 2022. We hope to host our annual meeting live. It'll be held at venue 610. We'll be addressing the opioid crisis and other key issues at this meeting. Follow us on LinkedIn, our blog, and check the IOMC website for more details. I would also like to thank our sponsors. They've been very critical to our ability to sustain these programs over the past 14 months. They include Blue Cross and Blue Shield of Illinois, Northwestern Medicine, Rosalind Franklin University, University of Chicago Medicine, the Portis Foundation, the Michael Reese Research and Education Foundation, the Washington Square Health Foundation, Hectone Institute, Complete Care at Martha's Health and Wellness, Care Advisors, and Golden Square. We're thankful for our sponsors. Thank you so much. So let's get on with the program. Our distinguished speakers are Dr. Melanie Dreyer, a fellow of the Institute of Medicine of Chicago, and she's the Dean Emeritus of Rush University School of Nursing and an anthropologist. Dr. Jeffrey Hergenrather. Dr. Hergenrather is the founding member and president of the Society for Cannabis Clinicians, and Ms. Eloise Thyssen is a geriatric nurse practitioner and president and a nurse and president of the American Cannabis Nurses Association. They will share more about their experience and expertise today. Please visit our website to learn more about them in detail. By attending today's session, you will learn the experiences of practice in which the desired treatment is designated as illegal by the federal government and not subject to payment by insurance. You will identify with the subtleties around dosage and consumption of a plant-based medicine, including the significance of the relationship between patient, provider, and producer of the medication. And you'll appreciate the range of therapeutic application of cannabis for patients of all ages and the critical need for continued research in both practice and pharma. It's my pleasure now to introduce Dr. Melanie Dreyer. Dr. Dreyer, welcome today, and thank you so much for joining us.
Thank you, Dr. Whitaker, and good afternoon, everyone. My journey with cannabis began in a mountain village in Jamaica in the West Indies, where as a doctoral student in anthropology, I conducted an early cross-cultural study on the use of marijuana, or ganja, as it's called in Jamaica, thus beginning 4 decades of funded ethnographic research in cannabis. I quickly determined that while smoking ganja cigarettes was integral to the work life of rural men in Jamaica to enhance their productivity, it paled in comparison to the consumption of ganja teas and tonics and topicals prepared by village women folk to treat upper respiratory conditions, including asthma, gastrointestinal ailments, diabetes, glaucoma, GU problems, and skin abrasions, burns, and insect bites, just to name a few. Ganja was the go-to remedy for pain, nausea, inflammation, and fatigue. And moms routinely prepared ganja tea for their children at breakfast to enhance their school performance. I can assure you, when I presented these findings at meetings back in the 70s, no one believed me. And I myself wondered, how could one plant have all these salubrious effects? Fortunately, our real-world evidence from Jamaica was soon legitimized by laboratory studies at St. Louis University and Hebrew University, culminating in the discovery of the endocannabinoid system, which you will hear much more about with our speakers. That said, the therapeutic use of cannabis, even in this country, is not new. By the end of the 19th century, cannabis was the single most common ingredient in the American pharmacopeia. Doctors routinely prescribed cannabis products manufactured by venerable pharmaceutical companies such as Merck and Eli Lilly. In the 1930s, however, it became the scapegoat of the Depression, attributed to Mexican immigrants, renamed marijuana, and made illegal by Congress in 1937, despite intensive and desperate lobbying efforts by the medical community and pharmacy. The 1944 New York Academy of Medicine report declaring that marijuana did not induce violence, insanity, or sex crimes, or lead to addiction or other drug use held no political sway, and it has been illegal ever since. While cannabis remains on DEA's Schedule 1 under the Controlled Substances Act, it has been fully legalized in 24 states and the District of Columbia. It is completely illegal in only 7 states, which constitute collectively only 1% of the US population that has no legal access to cannabis. Surprising to many naysayers, since state legalization, cannabis use has decreased among teenagers while increasing steadily among persons over 65, whose most common complaint is the difficulty in getting information from their providers. That is why we are here today. In closing, I would like to first offer my thanks to President Whitaker for her vision and courage in bringing this controversial topic to the IOMC members, and second, for hosting 2 of the best known and highly respected cannabis clinician leaders in the United States and abroad. We look forward to your questions. Thank you so much.
Thank you, Dr. Dreyer, and thank you for helping us to identify our next 2 colleagues here who are going to really educate us in a very short period of time, to the extent possible, about cannabis and its therapeutic opportunities and applications. So, Dr. Hergenrather, welcome.
Thank you very much, Cheryl. I appreciate the invitation from the Institute of Medicine Chicago and the opportunity to speak to some of your members. My name is Jeff Hergenrather. I am a physician. I'm a medical doctor, and I've had about a 45-year history in general practice, emergency medicine, and then for the past 22 years as a cannabis consultant, opening an office to counsel people about the use of cannabis since 1999. I would say mine has been a unique experience as a solo practitioner because I'm not limited to the healthcare companies, professional societies, and practice groups, limiting my access to or use of, I should say, cannabis as a medicine. As was mentioned, I was a co-founder of the Society of Cannabis Clinicians. I have stepped down from the presidency, but the organization is stronger than ever. It is a nonprofit organization dedicated to education, research, and patient care. Next slide, please. I show you this slide simply representing the animal kingdom because except for insects, the endocannabinoid system has evolved along with these very primitive creatures for somewhere in the range of 600 million years. The purpose of this system is to assure our survival by directing us toward homeostasis. It's a modulatory system that works on demand to bring homeostasis to the body. Next slide. This slide represents the dominant 2 cannabinoid receptors. There are probably somewhere over 20 receptors that respond to the natural cannabinoids, but CB1 and CB2 are the dominant cannabinoid receptors in the body. The endocannabinoid system is composed of transmembrane receptors, as kind of shown here, where the receptor is formed down in the cell, migrates into the cell membrane, and is available for activation from there. It is the receptors, the endogenous ligands, the proteins involved in synthesis, transport, and metabolism of the receptors and ligands. These are G protein coupled receptors, and CB1 is the most abundant G protein coupled receptor expressed in the brain. It's primarily, CB1 is located in the central nervous system and in nerves and organs and tissues throughout the body. The CB2 receptor, represented by the green dots, each dot being an amino acid, is a receptor found in the immune system. More about that in a minute. Next slide. This is an image of the CB1 receptor in the brain. By radio labeling a cannabinoid, you see the dense expression in areas of the brain. For constraints of time, I won't list them by rank order, but you can see that they are located in various places in the brain. The receptors are located on the presynaptic cells, and they're activated by endocannabinoids that come from the postsynaptic cells. So crossing the cleft to downregulate the neurotransmission. So when the neural activity picks up, the endocannabinoids are released, they cross the cleft, activate the cannabinoid receptor, and turn down the production and release of neurotransmitters. It's a calming effect in neural activity. Receptor activation is by either these endogenous cannabinoids or plant cannabinoids, hence the way that cannabis works in the body. It directs the body to homeostasis, as mentioned, and that would include eating, sleeping, relaxing, forgetting in a good way, and protecting. And this protecting function prevents excitotoxicity. It lowers blood pressure, it's a bronchodilator, it lowers intraocular pressure, and many other things. Next slide. This is the image of the CB2 receptor in the body. It's again from a radio-labeled CB2 agonist, and it's located in the immune system. There are fixed locations in the liver, spleen, tonsils, and thymus, but also a mobile system of cells that includes T and B lymphocytes, monocytes, and macrophages. These have a house cleaning role in the body, extinguishing abnormal and worn out cells, even cancerous cells, at a rate of about 1 million cells per second. Cannabis phytocannabinoids augment this house cleaning role. Next slide. This next slide title indicates the variability of the human CB1 receptor. And I think this is valuable for clinicians to understand. One after another, studies of the genes that make up the CB1 receptors reveal clusters of receptor variations that are associated with specific disease entities. Next slide. We all have an endocannabinoid system. You can't live without it. They don't work the same from person to person. The single nucleotide polymorphisms, or SNPs, reveal the genetic variability and the spectrum then of clinical endocannabinoid variations or deficiency syndromes. Next slide. One of two lists are here of the endocannabinoid deficiency diseases. Note that these polymorphisms give us evidence of these inherited conditions. They might not be totally compelling to inherit these conditions, but they certainly would provide some tendency to do so. As you look through this list, these are the conditions that we're treating with cannabis. And some of these conditions are ones that we haven't known much about. Irritable bowel syndrome or fibromyalgia, to name a couple of them. Next slide. This is the second page of conditions. And, you know, I only say I hesitate to call them deficiency diseases because here's happiness at the top of the list. Matsunaga in Japan showed that people that tested very high in a questionnaire for happiness, they too have a similar CB1 receptor. We'll talk more about bipolar and depression and ADHD as we go along. Next slide, please. So I'm going to switch here to CBD because it is all the rage worldwide. It has international popularity, and I think this popularity is based in the fact that it is not a psychotropic compound, and it has several of the cannabinoid medicinal effects. CBD, is it all we need from cannabis? Well, not at all. There is an entourage of the 100 or more cannabinoids, including THC, in the cannabis plant, as well as terpenoid and flavonoid compounds, making the whole plant much more useful and potent medicine. Next slide. This is a brief show of some CBD dominant strains of cannabis. On the left, you see hemp grown for fiber. And on the right, we see high CBD plants from Oregon. As long as the THC weight does not exceed 0.3% of the dried weight of the flowers, it's considered hemp and not under the regulatory control of Schedule I drugs or marijuana. Think of these two cultivars as really the ends of a continuum of CBD dominant plants, from CBD hemp to the fibers to the CBD grown for medicine. Obviously, on the right, these buds are much more, they're much larger, they're much more rich in oils. They might be 20% cannabinoids in the dried flowers. And they're also more rich in the terpenes and other active constituents of the plant. Next slide. So here's a list of pharmacologic actions attributed to CBD cannabis. There are numerous pharmacologic health effects here, and they are supported by research papers in cannabis and cannabinoids. But there is an aspect about CBD that you should be aware of. Next slide. In this work by Lilly a few years ago, she showed that CBD performs quite differently if it's a single molecule, an isolate, as compared to CBD as one of the dominant or the dominant cannabinoid in a full spectrum plant extract. So the two graphs on the left are with single molecule CBD, the two on the right with the whole plant extract CBD. Same milligram doses are compared. So on the left, you'll see on both the upper and lower graphs, one is a paw thickness graph in a rodent that had an injured paw. And as the dose goes up on the cannabis, the swelling comes down. But as the dose continues to go up, the swelling goes back up again. Similarly, below, the pain withdrawal response is optimized at a certain point. But as, again, the dose goes up, the effect is lost. So this is called a bell-shaped curve effect of single molecule CBD as compared to the two graphs on the right. And here we see that as we go up on dose, we have a continued effect, a linear response. So the bigger the dose, the bigger the effect. So simply, I would say we really are looking for cannabis CBD as a whole plant extract rather than an isolate in order to really optimize the use of CBD. Next slide. So this is to look at the the CBD and the THC briefly in terms of its effect on the CB1 receptor. THC activates the CB1 receptor. It's a potent partial agonist at CB1. When CBD is there in any significant proportion, it bumps the THC off of the receptor and reduces the psychoactivity in doing that. It is called a negative allosteric modulator because of this effect. CBD, though, has numerous other effects that we look to because it actually is called a promiscuous ligand for 65 discrete targets of action. Next slide. This is a table of these targets of CBD at the top, and then several of the minor cannabinoids below that. And again, for lack of time, I don't want to dwell on it, but CBD does not activate CB1 or CB2, but it is active at TRPV receptors, TRPA1 and TRPM8 receptors, either positive or negative. It's active at PPAR receptors, which are nuclear receptors. It has an effect on enzymes, and I'll briefly mention Pha, or fatty acid amide hydrolase, which is the enzyme that breaks down the dominant, one of the dominant natural cannabinoids, anandamide. We'll talk more about this in a bit. Next slide. So this is comparing the images of what anandamide looks like as compared to THC. And I think this is quite helpful in understanding that here's anandamide and THC with quite a similar morphology. THC is able to get into the receptor. That narrow tail end of it is what fits down into the depths of the receptor. For THC, it's able to activate it. CBD, on the other hand, has an opened ring at the top of the molecule, making it much different shape at the top. So again, it is not fitting into the cannabinoid receptor. Next slide, please. This is the expanded list of pharmacologic aspects of the phytocannabinoids of cannabis. Compare now this expanded list to when it includes THC. There are thousands of research papers in the literature that show the evidence of these actions of THC and the other phytocannabinoids. Next slide, please. So it came as an epiphany to me, really, to understand, to learn some of the neurobiology of ADHD and its strong familial link between ADHD and bipolar disorder and other psychiatric disorders, including depression and anxiety disorders. Similar regions of the circuitry in the brain are involved in these disorders. The neural pathways are comprised of what it's called the limbic, cortical, striatal, pallidal, thalamic circuits. These circuits are principally activated by glutamate and GABA. These neural circuits are modulated by endocannabinoids. So by activating these CB1 receptors, we're downregulating these overactive circuits. This fits well into what I've seen in my practice for over 20 years. I've learned from my patients that these mood disorders, that cannabis makes them feel normal. And in a paper that I authored last year about the use of cannabis in adult ADHD, in all but one of over 50 subjects, there was a strong preference for the use of smoked high THC cannabis by the subjects to provide the best relief for ADHD. Interestingly, the more cannabis prescribed, the use of conventional pharmaceuticals was significantly reduced or not used at all. Next slide, please.
So Jeffrey, you have about 3 more minutes, okay?
Thank you. I think this is helpful for docs when you get into using cannabis or recommending cannabis, I should say. The ratio of THC and CBD gives us a pretty good idea as to what we can anticipate for psychoactivity in cannabis products. Of course, the high THC is highly psychoactive in low doses, but the benefit is a stronger activation of cannabinoid receptors, including CB1 and CB2. The balanced THC and CBD medicine is able to reduce psychoactivity while preserving most pharmacologic properties. And the high CBD variants are not psychoactive, but their pharmacologic effects are blunted. There are at least 100 minor cannabinoids, each with its own spectrum of pharmacologic properties. Just to name a few are some of these pharmacologic effects of these several minor cannabinoids. Next slide. The next group of slides is really looking at discovery of the effects of minor cannabinoids. And without elaborating on this, 50 years ago, we learned that smoking high THC cannabis reduced intraocular pressure. Look at the numbers for yourself. It's in JAMA. But CBG has been discovered to lower intraocular pressure, as well as CBN. And CBD actually raises intraocular pressure. So high CBD is not your best choice. New line. Or new slide, I should say. This I'd love to spend more time on, but 3 strains of cannabis were used on 3 cancer cell lines. This is in vitro work with cannabis cells, with cancer cells being grown in Petri dishes. And you can see that for extract 1 and 2, it killed most of colon and breast cancers, but didn't do much for prostate cancer. And then in extract 3, it didn't do much at all for colon and breast, but did for prostate cancer. And what we learned from the laboratory after they went to a great effort to isolate molecules is that, to our surprise, CBD, CBDV, and one of the unnamed cannabinoids, 331.18B, killed all of these cancer cells. And the next slide is showing that a group of minor cannabinoids seem to make the difference in treating autistic kids in Israel. Compound 266 was working very well. It was switched to another compound, that compound 267, with almost identical CBDA and THCA. But the minor cannabinoids were quite different. The kids on the new product got violent, anxious, and did not do as well. They went back to the original compound and the kids came under control again. So I'm probably about out of time, but this shows the variability of 36 different cultivars with 93 of the cannabinoids listed. And what I want you to appreciate is how different each variety of cannabis is. So if somebody's trying cannabis and they're not getting the response that we're looking for, I get to a point after adjusting for dose in just telling people to go to a different strain of cannabis, and they may very well find something that works much better for them. I think at this point, I'm going to have to pass the baton over to my colleague, Eloise. There is a list here of dosing tips that I think are very useful. This is metabolic differences. This is the book that tells the story about therapeutic uses. And I will end my talk a bit prematurely, but please look to the slide set that is being published by IOMC. And thanks so much for your attention.
Thank you, Dr. Hergenrather. Perhaps during the Q&A, you can come back to some of the therapeutic
I'd like to do that.
and ideas. Yeah, I think folks will like to know about that. But Eloise, I'd like to turn it over to you. Thank you so much for joining us today.
Thank you so much for having me. It's an honor. And thank you, Dr. Hergenrather. I'll hopefully piggyback on a lot of what you said and offer some information about clinical implications. But just really quickly, I am an adult geriatric primary care nurse practitioner in California and have a clinic with my physician where we've now treated over 7,000 patients. And the average age of our patient is 76. They're predominantly cannabis naive and predominantly female. And of course, they're looking to treat age-related and chronic illnesses like pain, sleep, anxiety, and most don't want to smoke it, and most don't want to get high. Next slide, please. So I'll talk just a little bit about the cannabinoids, predominantly THC and CBD, but Dr. Hergenrather did a great job talking about the endogenous. I'll talk a little bit about some of the plant and synthetic cannabinoids as well. Next slide, please. And if you just hit enter again, it'll have a nice little, there we go. Thank you so much. So we do have some FDA approved cannabinoids. We have dronabinol, which was approved for nausea and vomiting and appetite stimulation, with the average dose between 2.5 to 20 milligrams per day. And nabilone, which is also known as Sesament, also approved for nausea and vomiting at 1 to 2 milligrams twice a day. These are synthetic THC components. They do not come from the plant. But we do have cannabidiol, also known as Epidiolex, which is originally starts with the CBD plant, but then is purified into about a 99% cannabidiol extract. And that was approved for 2 seizure conditions, as well as tuberous sclerosis. So now we have 3 separate conditions. And you look at average dosages between 5 to 20 milligrams per kilogram of body weight. Next slide, please. But when we're working with plant-based cannabinoids, there's different combinations of cannabinoids, and we refer to these as cannabinoid profiles. And you really need to understand the different benefits of each cannabinoid to really be able to match the product to help your patient the best. Next slide, please. And we have THC, and as Dr. Hergenrather mentioned, with our endocannabinoid system, THC does actually bind to our CB1 receptors, and this is where we see a change in the function of that cell, and it produces that euphoric effect. So it can alter our behavior, our consciousness, our mood, and our perception. Next slide, please. And one more enter, please. And we can see side effects that are dose dependent. So cannabinoids have this biphasic effect, and low dosages may produce one effect, where a large dose can produce the opposite. So we can see things like tachycardia, fatigue, dizziness, hypotension, even hallucinations, paranoia, anxiety, and amnesia in larger dosages. But in small dosages, we might see an increase in drowsiness, increase in appetite. And also THC is not a COX-1 or COX-2 inhibitor, so it can be a very powerful anti-inflammatory and analgesic. Next slide, please. And with CBD, as Dr. Hergenrather mentioned, it's all the rage. They seem to be putting CBD in almost everything. And it does have neuroprotective effects that are thought to be more potent than vitamins C and E. And it does have antipsychotic, anti-anxiety, antidepressant effects, and is considered a mood-altering substance. Next slide, please. It's very well tolerated and safe, even at high dosages. We've seen about 1,500 milligrams of CBD administered to humans that was well tolerated, but also can have side effects, which again are dose dependent. So we can see things like anxiety and tachycardia. We're more likely to see drug interactions with CBD, jitteriness, drowsiness, and even diarrhea. Next slide, please. But you'll often see CBD referred to as non-psychoactive, which is not truly accurate. It is not euphoric like THC, but can produce a psychoactive response. And I think it's really important that we communicate that with our patients so that they understand there are indeed some side effects associated with its use. Next slide, please. But as Dr. Hergenrather did such a nice job of showing that visual of the hemp plant, which can be used for industrial purposes. And then on the other side of the slide, he had CBD, which is coming more from the cannabis plant. And really, we want to see that type of plant used because the flowers are the best for producing the medicine. We've typically used hemp plants for stock, stem, rope, textiles, concrete. Next slide, please. And so here's another visual of what your hemp-derived CBD products should look like when they come from the plant, because as Dr. Hergenrather mentioned, hemp is legal as long as that THC is 0.3% or less at dry weight. So you will see plants like this, that flower, that many companies are now using to emphasize, they're growing it to emphasize the production and promotion of CBD from flowers. Next slide, please. And so now with hemp legalized, we see CBD products all over the marketplace, both in store and online. And there's a lot of confusion for our customers and patients who want to use CBD particularly versus THC. And so I just want to briefly touch on the 3 different types of products out there. We have full spectrum, which means that it contains all cannabinoids and terpenes found in the plant. And it's the closest form to the natural plant. So that THC is usually about 0.3% or less at dry weight. And that can go up when they concentrate the plant and make it into a tincture or a topical or a capsule. So there's definitely levels of THC in a full spectrum CBD product that can sometimes cause side effects like slight euphoria, drowsiness, or impairment. And usually we see that in the high concentrated CBD products of like 50 milligrams per milliliter of CBD or more. And then we have broad spectrum, which does not contain any THC. So they've removed the THC, but left the other cannabinoids and sometimes the terpenes in the product. And these are often labeled as THC free. And we'll see these products out there for those who are unable to consume THC or maybe still reticent to have THC into their regimen. And as Dr. Hergenrather touched a little bit on the entourage effect, we do really want to make sure we have as many cannabinoids and terpenes in that product to help with the best outcome. And then we have CBD isolates, which contain no other compounds from the cannabis plant. It's often refined into a powder or crystal and then reconstituted into a capsule or a tincture. Next slide, please. But with CBD hemp products that are on the market, they are currently not regulated. So you really want to make sure that patients are purchasing products that have been independently tested by third-party testing facilities. We want to make sure that the amount of cannabinoids and terpenes are displayed and that they're with each batch. We want to make sure they're using safe extraction methods so there's no residual solvents in the final product. And we also recommend that they're derived from high resin cannabis grown sustainably and organically. Next slide, please. So I want to talk about a couple conditions where cannabinoids can be most effective: appetite issues and nausea and vomiting. Next slide. We certainly have some data on our synthetic cannabinoids, or Marinol and our Nabilone. And what we're looking at here is some studies that have been done where CB1 activation, which again will be your THC, this is going to help produce that hormone ghrelin, which will increase food intake and increase the activity in the area of the hypothalamus that's responsible for nutrient sensing. And there was a study in HIV patients who inhaled cannabis that they tested higher for serum ghrelin, as well as reduced levels of the appetite suppressing peptide PYY. And I would say clinically in practice, THC seems to be the most effective for increasing appetite compared to CBD. And there's even some research that CBD can suppress appetite over time. So this is the THC seems to be the predominant cannabinoid for appetite. Next slide, please. And CBD has been showing great promise, as well as THC, in helping with chemotherapy-induced nausea. So in addition to the TRPV and PPAR receptors, we know that CBD can interact with our 5-HT receptors as well. So particularly our 5-HT3, and cannabis has attenuated chemotherapy-induced nausea and vomiting. Although there exists no clinical trials comparing inhaled cannabis to first-line antiemetics, and we certainly are seeing where cannabinoids can be effective. We do have multiple studies demonstrating that partial agonists at our CB1 and CB2 receptors, so that's our delta-9 THC and our synthetic delta-9 THC, are more effective than our old generation, the dopamine 2 receptor antagonists. Next slide. And we know that cannabinoids can demonstrate a synergistic potential in vomiting, particularly acute nausea and anticipatory nausea when combined with other antiemetics. So we do have data to suggest that delta-9, THC and CBD can have combined can demonstrate enhanced reduction of vomiting. Along with ondansetron, we can also see enhanced reduction of anticipatory nausea, which can be really useful considering we have no other FDA-approved regimens for anticipatory nausea right now in our chemotherapy patients. Next slide, please. And insomnia and sleep issues, as I mentioned, most people are coming to me personally to seek relief from insomnia or other sleep issues. Next slide. And I know that Dr. Hergenrather was hoping to get to this in his slides, but in 2017, the National Academy of Sciences, Engineering and Medicine did release their report on the health effects of cannabis and cannabinoids, and released the current state of evidence and recommendations for research. And in that review, they found that there was moderate evidence in the medical literature that cannabis and cannabinoids are effective at improving short-term sleep outcomes, with sleep disturbances associated with obstructive sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. Next slide, please. And we also have data to suggest that cannabis can help relieve symptoms associated with neuropathic pain. Next slide. Again, in their report, the NASM report, they found that there's conclusive evidence that cannabis or cannabinoids are effective for treatment of chronic pain in adults, and that cannabis in particular has been shown to be effective at reducing inflammation, modulating pain, boosting opioid analgesic effects, and shifting the dysphoria associated with pain. Next slide. And existing treatments for neuropathic pain in a 2017 review of over 100 studies of commonly prescribed medications for diabetic neuropathy, researchers at the Hopkins Group found that only moderate evidence for the efficacy of antidepressants, duloxetine and venlafaxine, and weak evidence for the efficacy of botulinum, pregabalin, oxycarbazine, tricyclic antidepressants, and atypical opioids. Next slide. We do have data to suggest that excessive concentrations, glutamate contributes to neuropathic pain, and CB1 receptors can play a crucial role in preventing the neurotoxicity caused by a release of glutamate. Cannabinoids that are CB1 agonists, so again, that's going to be your delta-9 THC, both from the plant is a partial agonist, and then your nabilone or your dronabinol are CB1 agonists. They might inhibit glutamate release and help alleviate neuropathic pain. In many commercial markets, delta-9 THC is the only CB1 agonist available. In mature commercial cannabis markets, however, you could consider using other cannabinoids like CBN or CBC, both of which are also partial CB1 agonists. I know we didn't have a chance to really tell you about those. Next slide, please. And chemotherapy-induced peripheral neuropathy. We do have some data coming out, particularly in animals, to demonstrate whether or not cannabinoids, particularly CBD, is effective in helping to reduce or even prevent chemotherapy-induced peripheral neuropathy. And we did have one study that assessed whether CBD can prevent the chemotherapy-induced peripheral neuropathy from paclitaxel in mice. They administered 2.5 to 5 milligrams per kilogram of CBD 15 minutes before each paclitaxel injection. And the development of the chemotherapy-induced peripheral neuropathy was prevented in the rodents that received CBD without compromising the anti-tumor effects of paclitaxel on breast cells. And an additional study was determined whether CBD or THC was helpful in preventing the chemotherapy-induced neuropathy with oxaliplatin and vincristine. And this study demonstrated that the two, using CBD and THC together, were better than using CBD or THC alone. So again, some more data to suggest the effects of the entourage effect. Next slide, please. I think I'm doing okay on time here. And we know that CBD, again, can help mitigate pain through multiple mechanisms. So it's not necessarily activating our cannabinoid receptors, but it can reduce inflammation and mitigate some of the unwanted effects of THC, as Dr. Hergen rather touched on. So things like lethargy, dysphoria, and short-term memory loss can be mitigated with the use of CBD. In isolation, CBD is effective for mild pain, but many patients state that CBD alone is not enough to control their pain. And a preclinical study found that low dose CBD helped prevent allodynia via the TRPV1 receptor activation and decreased anxiety related to pain. So often we'll see in practice many of the side effects that can symptoms that can come along with chronic pain, like insomnia and anxiety, can also be helped through cannabinoids. Next slide. And CBD can help opioids work more effectively, enabling patients to take lower dosages. While this was a small study of 29 patients, 15 patients randomly received a CBD topical, and these patients reported a reduction of sharp and intense pain, itching, and cold sensations associated with their neuropathic pain. And topicals typically don't provide or produce any side effects because they don't reach the bloodstream. So a very safe way to start our patients out on a cannabis product. Next slide. And again, CBD can help relieve the pain, itching, and inflammation, relieve pain related to inflammation and neuropathic pain, and protect nerves from damage. Next slide.
And Eloise, so about 2 minutes,
okay.
And we could try to transition a bit here.
Perfect. I got 2 slides left, so that works out well. Yeah. And THC can also be quite effective, again, for helping with pain, as it can produce analgesic effects by modulating neurotransmitters relevant to the transmission of pain, such as endogenous opioids. Next slide. But most importantly, we still go with the start low and go slow because many of our patients may respond to a low dose. Again, cannabis is biphasic, so those low dosages may produce the best effect, and a high dose may actually produce the opposite effect. So going low and slow can help so that they don't miss their therapeutic window. It can help reduce potential side effects and of course help with cost depending on what the patient needs. And with that, I yield.
Well, thank you all, very much. We know that there's so much more to share, but we're trying to pack it into an hour. Are there any questions from the group? I don't see any in the chat box. So Dr. Drow, did you have a question? I certainly have a couple, and then we can kind of go from there.
Well, I had a question, actually, just a simple practice question. You're in practices that with a drug that is deemed illegal at the federal level, for which there is no insurance payment. And how do you put together a practice in which you are compensated for the excellent work that you do and that patients are eager to come to? So how does it, what's the business model? I guess it's a little off the clinical topic, but I think we need more of you and we want to know how you do it.
I could start out with speaking to that. I decided that I was going to make a transition from emergency medicine after 25 or 6 years of ER work. So I looked to cannabis medicine as that choice. And I knew I was going to have a cash practice because there were no third-party payments. And that basically works out to just do cash payments. I started out with just requesting records so that I felt that I had evidence of the diagnosis that the patient was presenting with. And although it would be nice to be able to bill Medicare or whoever, it also is complicated, and it kind of simplifies the practice to just have it as a cash practice. It was a big step to go out of my medical community, my comfort zone, and into a private practice with cannabis. That's I really felt kind of estranged for a while, and docs that I thought would be supportive were just kind of like, well, good luck. But the support was not really very strong for a while. But I have to say, over these years, docs have come around. Physicians, I think, and healthcare workers are often the last to really appreciate the value of cannabis because we have not been allowed by the district court, federal court, to aid and abet patients in getting their cannabis medicine. We have to really hold off from that role of saying, okay, here's where you go and here's what you get. We do that anyway, quite honestly, but we have to be, I think, discreet about it. The cannabis dispensaries are very useful and very helpful, and we do communicate with them directly. But more often we ask patients to step into the dispensary and see what might be available in, let's say, a CBD product or a balanced THC CBD product and so forth. So we'll direct them, they'll see what's available, and then we communicate back and forth with the patient. Sometimes in the case of patients in nursing facilities or residential care facilities for the elderly, we may have to actually write a treatment plan to the facility and say, please assist this patient in taking this medicine in this way. So it does work out, but it took a while before I really felt comfortable in doing this. There was a lot of anxiety for the first 5 or 10 years, but lately I get a lot of referrals from docs who just don't know enough about it themselves, so they're happy to have somebody to refer their patients to.
So we have a couple of questions here. It says, one for Dr. Hergenrother, in your patients that are taking high dose THC to treat ADHD, do they need to take drug holidays to reset their tolerance to THC?
I do encourage that, and it's a good question. And I think there tends to be a natural course that would be taking a holiday from it. So I do both encourage and see that people will use it daily, once daily, 2 times daily. If they're using a ADHD medicine, it's often because they're in a work environment and can't use a high THC before going to work. So they'll come home, and after work, they might use the THC once or twice throughout the rest of the day. But there just seems to be a natural tendency for many people to take a little break for a few days and then get back into it. And I think this is a valuable way to reset these cannabinoid receptors in the brain. We didn't spend much time talking about it, but that's what we call tolerance. And what that means is the population of CB1 receptors auto-regulates. So if there's a lot of cannabinoid around, a lot of THC around, that population of receptors will diminish. And if we give it a rest for a couple of days, it resets. The receptors come from intracellular back into the cell membrane, and they're active again. And as Eloise points out, we start low and really encourage people to use just what they need. And it is a good way to reset the receptors.
And so, Jeffrey, just when you talk about ADHD and the THC, is this are people taking a pill of some sort, guys, for ADHD, or are they smoking the cigarette? Like how do you treat ADHD with the THC? Just,
you know, I think we can encourage people to use oral products. And I think logically, if we're not irritating the lungs, that makes sense. But in the study in Israel that we wrote up last year, it was very interesting because a patient can go to a dispensary with a prescription from a doctor in Israel, and they are allotted a certain amount of grams per month of cannabis, and they get to choose. Do they want to get a tincture, an extract, or do they want to take the flowers home? And in all of the patients, they chose, in this cohort of 53 patients, they chose flowers, and only one of those was of CBD cannabis, and all the rest were high THC cannabis. So in a way, you're getting more bang for the buck. You're just getting a stronger medicine that was working better to be an agonist at those cannabinoid receptors and downregulate the overactivity of the brain, and it worked quite well.
We've got 2 questions here in the chat Q&A. Given the psychotropic effects, and I'm assuming that means given the psychotropic effects of THC, there's an assumption here, is there any work that demonstrates the efficacy with borderline personality disorder?
Well, that's a good question. And I think we have to be willing to work with psychiatrists and other and primary docs to work with people with borderline personality, because there may be some hypomania that presents, or some other issues. Frank psychosis is not very common, but naturally it does occur in bipolar disorder. So we have to, I think in general, we get a calming effect with the THC, and in general, I would say this is not psychosis inducing, although that's a fear that's put out there about high THC cannabis. But again, I think it's important to be working with the primary docs and working with psychiatrists to balance the treatment plan for people with some of these mental disorders.
Eloise, this might be a good one for you. They're asking, are combinations of CBD and THC effective for arthritic pain? But maybe it's what combinations are effective, and maybe how do you determine the treatment? Because I imagine your practice, this is something you see quite a bit.
Yes, yeah. And I usually answer that with it depends, right? Because everybody's so different with their endocannabinoid system, and everyone's so many different products out there. I take many factors into consideration: their age, their alcohol intake, their other medications, what kind of support do they have, have they ever used cannabis before, and then we'll usually make a recommendation from there that could, I would say on average, I do a pretty high CBD to THC regimen to start and see how they tolerate that, and then we'll start adding in THC based on their response.
And then, so I have two questions that one of the things you all said was that, the endocannabinoid system is different in different people, meaning there are different types of receptors are more or less present. And I'm just wondering, how do you figure out, how to match up, right? Unless are there precision medicine tools or techniques available so that you can sort of map to that person and make the most efficacious treatment sooner rather than later?
Well, that's a good question, and it's one that is more wishing that we had more information. In California, people would take their cannabis to the laboratory and come in with a rundown of 15 or 20 cannabinoids and 15 or 20 terpenoids that were in their cannabis plant. And it would be interesting for them to learn and for me to learn what was there. What we have found in the California law now is we only look at THC, CBD, and CBN. So we're not looking at all at the minor cannabinoids or the terpenes, and they do play a role. So we do try to tailor the medicine to meet the patient. And I always start with a family history to find out what's going on in their family history, and maybe have some better notion as to where we might go with cannabis for them. Again, it's a trial and error. And for many people, I just have to say, look, we can start here. Let's say a 1-to-1 THC CBD tincture, and we'll see how it goes, but expect that we are going to need to make adjustments, not only in dose, but maybe in going to other plant cannabinoid ratios as well. So it is a trial and error kind of a practice, and some people just take to it easily and look to other products and experiment, and they're comfortable with that. Other people, you've got to hold their hand and talk about each milligram change, and that's just the way it is in medicine.
And then are there vendors that you're more comfortable with, or where they source their CBD, CB1, CBN from? Or should we just all go to the, drugstore? I mean, not the gas station, because they have CBD on the shelves. Are they different than what you guys use? Or do you have kind of more ones where you trust the integrity of the plant and what they're saying is in it? How do we know? Because it's really everywhere. It's literally like in the soap at Nordstrom. I mean, it's so like, where do you all get it? And how do you decide what vendors you use to
Eloise, your thoughts? I mean, I could speak about it too, but
Yeah,
go ahead.
thank you. Yeah, it's complicated. I mean, there's over 3,000 CBD companies in the US market alone, right? There's a lot of consumer confusion out there. So there's a sort of a vetting process that I'm sure Dr. Hergenrather has similar to, where we look at the certificate of analysis to verify that it's been tested for certain things like mold, pesticides, fungus, bacteria, residual solvents, potency. And then, for me, I've compiled like a handful of CBD companies that I trust and have a variety of products and a variety of potency, and look for the most cost effective, because most of my patients, I mean, one of the things that when you're talking about starting a practice is not only it's a cash practice for the clinician, it's also cash for the cost of the medicine. So you're looking at the health disparities that can happen in patients that want to use cannabis instead of their opioids. You have maybe paying $5 prescription a month for opioids versus maybe $100+ a month for cannabinoid treatment. So really looking at what's the most cost effective for the patients too is really important.
I might add that in California, probably everywhere, you have to buy the THC products in the dispensaries, but online we have a number of reputable companies that sell CBD products and CBG products and THCV products and so forth. Some of the minor cannabinoids can be sourced from online vendors. So I will often send out a list of about 10 that I think are reputable, and often very compassionate, and give better prices to people who are in chronic situations. So I do encourage people to consider sourcing medicine online if cost is a big issue for them. It does make a significant difference. You can get down to about a nickel a milligram for CBD online.
One of the, I was at a community event, and there was a vendor selling Delta CBD, and a couple people said, "Could I ask you guys about this other variant of CBD? It's called Delta." I don't think I'm being funny, right? Delta variant, but I think this is. Is this something you guys have heard of, and do you have any thoughts on it?
Without knowing delta something. I mean, we do have delta 8 THC, and it's supposed to not be psychoactive, but it probably has some psychoactivity. And people in states where they're not allowed to use THC might source that. But I'm not sure what delta CBD would be, quite honestly.
Yeah, I think it's what I believe you're correct in what you're talking about.
There's very small amount of delta 8 THC in cannabis plants, some with more than others, but it is one of those other isomers that can show up, and it may very well have some significant therapeutic value. We just I'm a little nervous about it because people are rushing to meet orders, and I think they cut corners. They may cut corners and provide some products that aren't as clean or as safe as they should. So I'm a little wary about some of the companies out there.
Yeah, and I think maybe that question's coming from the fact that many of the companies are taking CBD and synthesizing it into delta 8 THC. So there's a lot of chemical uses of chemicals in that process. And as Dr. Hergen rather said, with the testing of course, it's not being regulated. So we've had huge increases in poison control calls in states where delta 8 has been offered because there's either a large amount of delta 9 THC in there, so they are getting impaired, as well as other chemicals that we don't know about.
And then is there a school or a class or courses that if people are interested in learning more about how to do what you all do, is there a certification or any formal certifications that people can get or classes that people can attend?
Well, there is a educational program in Oakland called Oaksterdam University, and they actually give a certificate when you've spent many days of training there. I don't currently know anything about their process to educate people, but historically they've been very helpful.
There have been, if I could just interject for a second, there have been several universities across the country that have opened master's degrees in cannabis science, and that would prepare people. And not just health professionals, but people who are just interested in this and see themselves somewhere in the industry eventually. And you can go online and find these master's programs. And I think there are continuing education programs too. So they are, to your point, Dr. Whitaker, there are definitely those programs available.
Are there any other questions or comments that either of our speakers would like to make? I know, Dr. Hergen, rather, there were several slides of yours that we didn't get to. Are there any high points you'd like to share, things you didn't get a chance to cover?
Well, I could mention an aspect of the NASEM book, the National Academy of Sciences, Engineering, and Medicine book that came out in 2017. This is a great resource, but I think that it's good for people to recognize that we don't necessarily see in this book the support of the literature in treating many of the conditions that we treat in our practice. So for degenerative diseases that Eloise is seeing so much of in her population of patients, and really in my practice as well, let's say MS, for example. I find wonderful results in MS patients, for example. So why don't we see the clinical benefits of cannabis so frequently described by patients matching the current scientific evidence? Well, I think it's best to just recognize that this book has its limitations. It's only looking at papers between 1999 and 2016. So it excludes anything that was done prior to 1999. It excludes all animal and cell studies despite their relevance. So as I was talking about some basic science that has occurred that I think is a helpful guide to us for developing cannabis medicines, that's not included. It excludes all case reports. So if you do a hunt for case reports, you'll find doctors talking about tumors disappearing or benefits in certain conditions. Those case reports don't make it into the literature there. It's English language only. It's often looking at single molecule studies. And as we've pointed out, the whole plant is a much different medicine than are the single molecules. And finally, I think even the book admits that it excludes very good research that simply did not address the health endpoint questions of the committee that wrote the book. So we, as clinicians, we're seeing a lot stronger evidence of benefit of cannabis medicine than we're necessarily going to read in this particular volume that is esteemed, but it just doesn't really fully appreciate clinical medicine.
Thank you. Are there any other questions from our audience? I don't see any right now. So I'd like to invite the panelists to make any closing remarks that they have as we wrap up our session. I think this has been extremely helpful. There's a lot to learn and to know in this space. So, and thank you, Patty. Patty said exceptional presentation. So do you want to start with you, Eloise, in terms of closing remarks, comments, or anything else you want to share with the audience?
Yeah, I mean, again, thank you so much for being here. It's such an important topic, and we know our patients are using it. So it's exciting to see Institute of Medicine in Chicago offer this opportunity for clinicians to start getting some foundational knowledge. And there are, as Melanie said, some great institutions out there, Thomas Jefferson University, University of Maryland, that are starting to offer master's degrees. I know Society of Cannabis Clinicians has some great continuing education content, as does the American Cannabis Nurses Association. So, you know, keep an eye out for those organizations that are really trying to help increase education for clinicians so we can help our patients.
Thank you.
Great.
Jeffrey?
Yes, I would like to speak to what I hear from docs a lot of times is we need to see the randomized controlled trials. We need to see the research, and it hadn't been done. So how can we possibly work with cannabis? Research in the United States is administered by the National Institute on Drug Abuse. It's not for drug abuse, it's on drug abuse. This research is limited to studies of harm and of drug abuse studies. It does not include any studies looking for the therapeutic use of cannabis. So it's nearly impossible to implement a randomized controlled trial with cannabis looking for therapeutic potential because of this regulatory prohibition and the cost of designing studies. And I think too, we fall into looking to the media, and the media tends to sensationalize assertions of harm while ignoring significant beneficial effects of cannabis and benign findings in cannabis research. So I think in the future, as we go forward, we really have this great treasure trove of cannabinoids in cannabis. And I think when we have the opportunity to discover more of these, of the therapeutic uses of these compounds, we're going to be able to tailor medicines to better meet the needs of our patients. And I think it's an exciting time looking forward, as long as we are able to really get this out of Schedule 1 so we can go forward with the research that needs to be done. So yes, thank you for your attention.
Thank you. Melanie, and thank you for helping us to identify Ms. Tyson and Dr. Hergenrather. Very, very appreciative of you helping us to put this together. Do you have any closing remarks or comments to share with the audience?
Well, both of them are my heroes for sure. And I think they both know I can take a little more philosophical approach to cannabis because of all my years working in a country where this was just part of normal life. It was not a big deal, and it was used prodigiously and well to improve people's lives. I worry about this. This is a more philosophical position, this paradigm that we have gotten ourselves into, that it's either medicinal or recreational. And this is a plant that has enjoyed thousands of years in a symbiotic relationship with mankind that has improved the lives of people and helped us to live well. And when I think of many people I know, business people, high level people who come home in the evening after their work and sit down and inhale a bit of cannabis or have a cup of cannabis tea to relax, I don't consider that recreational. In fact, most of the use of that's non-disease oriented of cannabis is hardly recreational. It's improving the quality of their lives. And I hope that as we move toward perhaps a more liberal approach to cannabis, that we do not get into this sort of intense medicalization and everything else is out there just having fun with cannabis with all our friends, because it's not like that. It's not a substance like that. And I just hope that the American public, I think, has already realized that, but that we need to really think about this dichotomy between medical and recreational as not a good dichotomy and not a good paradigm. So I leave you with that.
Well, thank you all so much for joining us today. Thank you to our audience. Thank you to the Institute of Medicine Chicago Board of Governors who allowed us to really begin to kind of lead on this issue and bringing it to our colleagues. And so that ends our presentation. And we look forward to the next one, and we look forward to seeing everyone soon. Thank you all and have a great day.
Thank you.